Hey, 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 check the time, check the time. What time is it? What time is it? What time is it? It's EKG time. It's EKG time. With rhythm and beats. With rhythm and beats. Go EKG. Okay, we're going to get started. But first of all, you guys know what to do. We're going to be on chapter 14, myocardial infarction. All right, here we go. You know, we got to get our minds right and our hearts ready. So let's go. All right, everybody all pumped up and ready to go? Here we go. So here we see an illustration of a person who has um, coronary artery disease, and we see they have the plaque buildup, and then we get the blood clot, and of course, if not treated, then that's when they get the MI. Okay, and this area right here is where you have the tissue infarction and tissue death. So what is acute myocardial infarction? Acute myocardial infarction is the rapid development of myocardial necrosis caused by a critical imbalance between the oxygen supply and the demand of the myocardium. It is an irreversible myocardial injury from prolonged ischemia. Accurate and early diagnosis is important in minimizing the cellular damage and consequently in obtaining a successful outcome for your patient. Myocardial infarction involves the death of the myocardial tissue in an area where the coronary artery has been blocked. The process begins with ischemia or lack of blood supply, and then it progresses to injury to the area, and then the blockage causing the infarction. Ischemia and injury are reversible if you're able to restore that patient's circulation to that area. However, once that tissue infarcts, it's permanently dead, okay? Because your myocardial cells do not regenerate. So here's an illustration of a beating heart with showing you the dead heart muscle in the area where someone's had an infarction. Okay, in previous lectures, we talked about the three layers of the heart muscle. You have the endocardium, the myocardium, and then the outer layer, the epicardium. It's this myocardium right here is the layer that usually destroyed by a heart attack. So there's two types of myocardial infarction. You have your ST elevation, which is called the STEMI, and non-ST elevation, which is your non-STEMI. Now, STEMIs are usually, they usually damage the entire thickness of the myocardium. They result in ST elevation, T wave inversion, and significant Q wave. And the person with the STEMI is usually going to present with the symptoms of an MI. Now, your non-STEMI is usually incomplete, and it only usually causes damage to that innermost layer of the myocardium just under the endocardium. They result in widespread ST depression instead of the elevation and T wave inversion. Patients typically go on to have a STEMI within a few months if they don't get treatment at the time that they have the non-STEMI. Okay, so here's an illustration of your STEMI versus your non-STEMI, and it's just showing you the area here where we see a patient that has a non-STEMI. There's that area that of tissue death right here, but you still has some viable tissue left. Whereas with your STEMI, it destroys the entire wall of that area. Okay. Here's an illustration of EKG strip showing your non-STEMI and your STEMI. Here's your ST depression with your non-STEMI and your ST elevation with the STEMI. Here's an illustration showing you your normal ST segment and then your ST elevation again with the STEMI, ST depression with your non-STEMI, and here's what the T wave inversion looks like. So now on this illustration, it's showing you how if you're looking at the strip and you can draw you an imaginary line, find your baseline here, and then draw you an imaginary line across here, you can actually see more clearer of the ST elevation for someone who's having a STEMI heart attack. So our ST elevation is our earliest reliable sign that a myocardial infarction has occurred. Let me see that here. So let's talk about what kind of symptoms that patient may present with. They may present with a sudden onset of substernal pain. They may express it as feeling crushing, tightness, feeling like an elephant sitting or standing on their chest, and their pain is usually unrelieved by the nitroglycerin. They may say the pain feels like it's radiating to their back, their neck, their jaw, shoulder, or arm. They may be short of breath, decreased blood pressure, nausea, vomiting, have extreme weakness, sweating a lot, and oftentimes they'll deny that they're having the symptoms of a heart attack. So here are some other nonverbal communication that a patient could be having a heart attack that you may see, such as they're grabbing their chest, their arm, or their neck, grabbing their chest and experiencing shortness of breath, grabbing their head and feeling lightheadedness or breaking out in cold sweat, or grabbing their stomach with stomach discomfort. Okay, so men and women exhibit different signs or may report different signs and symptoms of a heart attack. With women, they may report lightheadedness or dizziness, and women tend to report upper back pressure or chest pressure, whereas the man usually refers to it as pain, more pain than pressure. Women have shortness of breath, pain in one or both arms, the back, the neck, the jaw, or the stomach, feeling faint and extremely fatigued. And the man may also have the shortness of breath and exhibit the pain in one or both arms, the neck, the back, jaw, or stomach. And what's critical here is if you or someone you know are having any of these symptoms and they last longer than 5 minutes and you're not sure or the patient's not sure what's causing these symptoms, you want to immediately call 911, okay? Because the first hour within the onset of these symptoms is your critical hour. And if, for that patient to get treatment, anytime after that hour, the likelihood of that patient surviving that heart attack starts to decline, okay? So you have 3 areas of damage after a myocardial infarction. You start out with the area of ischemia, which can be reversed if they get treatment. And then if not, it progresses on to the area of injury, where you'll start to see your ST elevation. And then again, as time passes, that tissue will infarct. And at that time, you'll generally see the Q wave develop on your EKG, and that tissue has died, okay? And that once it gets there, it's irreversible, okay? Here we see an example of your normal PQRS and T wave, an example of ischemia with your T wave inversion, and then the injured tissue, you start to see the ST elevation, and then once that tissue infarcts and necrosis sets in, you'll see that significant Q wave. Okay, watch this illustration. It's going to wipe the EKG examples of each of those areas. So here you see that significant Q wave, your area of injury, and then your area of ischemia. Okay, T wave, your normal T wave should be rounded and upright in all your leads except AVR and V1. AVR's T wave should be negative and V1 can be flat, inverted, or upright, okay? All abnormal T waves can imply myocardial ischemia. So your T wave is very important. Hyperacute changes are those that accompany the earliest stages of an MI. And here we see that T wave morphology where we see what your normal T wave can look like. Here's a flat T wave. Here's one where someone has too much potassium. And we talked about in a previous lecture how you would have that tall peak T wave with hyperkalemia. Here's your inverted T wave with ischemia. So let's talk about your QRS complexes. Significant Q waves and poor R wave progressions are clues to an MI. A significant T wave implies myocardial necrosis. So by the time you see that significant Q wave on the EKG, that patient has, that tissue has died. For a Q wave to be significant, it must be 0.04 seconds or at least one small block, and we see that here, or 1/3 the size of the R wave, okay? On this slide, we see an illustration of your significant versus your non-significant Q wave. Here's your normal non-significant Q wave right here. And then here we see that deep significant Q wave with the infarct tissue. So here on this illustration, again, we see an example. It's going to write that Q wave for you. See here. Myocardial infarction, dead muscle tissue produces no action potential, okay? There's no electrical activity going on in that area. R wave progression. From V1 to V6, the duration of the QRS complex should change from negative to positive in a gradual manner. And we see here starting in V1, we see our negative, and then gradually it starts to become positive. And then you get to V4, between V3 and V4, you should start to see your normal R wave progression in which your R wave and your S wave will be just as much positive as it is negative. So here's an illustration of what the normal should look like as it progresses gradually. And then here, if you have poor progression, you see instead of gradually getting positive, it's getting more negative, and then, it's like it's unstable. And then here in reverse progression, it's backwards. It's totally the opposite. So here's a good illustration of R wave progression. We see here precaudal transition zone is when R equals S, which is usually around V4. And if you're still not sure, you can ask Miss Annie here. She's got her hand up to, she knows the answer. And here she's showing us it's right between V3 and V4. That's when you should see that area of transition. Okay, so you have no rotation if it occurs between V3 and V4. However, if it occurs in V2, V1 or V2, you have counterclockwise rotation. If it occurs in V5 or V6, you're going to have your clockwise rotation. So here's an illustration of an image. You may have heard people refer to an MI or a blockage as saying they have 100% blockage or 50% blockage, 80% blockage, and so forth and so on. This is what that looks like on the image when the doctor makes that determination. Okay, so here we see an artery with no plaque buildup. As you gradually get that plaque buildup, it just builds until it eventually blocks that artery off, and that's when you get that area of infarct. Okay, so here's an illustration of a healthy person, what their normal PR interval duration and segments should look like. And then here's a person who's having a heart attack. You'll start getting the ST depression, ST elevation, and that person can also progress through ventricular fibrillation. So you can determine the age of an MI. For example, may have a patient that comes in and gets an EKG, and when the doctor looks at it, he may tell that patient, well, you had a heart attack, and they say, what? Yeah, so an MI that has an ST elevation is an acute MI, meaning that MI has occurred within the last day or two. An MI with a significant Q wave and your baseline, your ST segments are almost back to the normal baseline, and you have an inverted T wave, that MI is said to be age indeterminate, meaning it could have occurred several days ago up to even a year ago. And sometimes doctors will refer to that as a recent MI. An MI with significant Q waves, your ST segments back to the baseline, and your T waves back upright is said to be an old MI, and that means it could have occurred weeks to years ago. Here's an illustration of what your EKG will look like. Here's with the onset in the first several hours. Here's after the first day, the first 1 or 2 days, after 2 to 3 days, and then here after several weeks. Okay, you guys, do y'all feel like this after all this information? Well, a little bit more to go. Let's keep going. Come on. Okay, so here's an example of a way to help you remember the order of your PQRST. So P is for the pain that's required for you to learn these EKGs. Q is for how quickly these facts disappear from your brain. R is for how ridiculously awesome a heartbeat is. S is for all the searching through the textbook you have to do to find the answers. And T is for always trying to decode that rhythm. Okay, here's another example. You can ask, how did Pamela fix her broken heart? Well, she was told, Pamela, quit reading sad song title. Okay, did you know? Did you know that the muscular walls of your right ventricle is thinner than your left, and why? Well, your left ventricle has to pump the blood from your heart out to the rest of your body, so it needs to be thicker and stronger than the left side, which only has to pump the blood to the lungs. Okay, here's an illustration that shows you which leads, if you notice that ST elevation in V1 to V4, that doctor will say that that patient has an anterior MI. Leads 1, AVL, V5, V6, a lateral wall MI, and so forth and so on, okay? Here's another example of that, and we see here you have the 4 walls of the left ventricle. You have the anterior wall, the lateral wall, the inferior wall, and the posterior wall, and it tells you here what artery supplies that area of the heart, as well as what leads. You'll see the EKG changes, and then also if you look in the leads opposite that, they should look opposite of the lead changes that is seen with the MI. And you can see an example of that page figure 1411, page 318. So here when you have the EKG leads on the outside of the patient's heart, this just gives you a visual illustration of the areas of the heart that those leads are looking at. Okay, so identifying a myocardial infarction location. Your 12-lead EKG can help identify which coronary artery or branch is occluded, as well as the area of the heart which has the ischemia, the injury, or the infarcted area. Leads 2, 3, and AVF provide a view of the tissue supplied by the right coronary artery, whereas your leads 1, AVL, and V1 through V5 and 6 view the tissue supplied by the left coronary artery. And here's another visual image just showing you those four walls of the left ventricle. Okay, so here's something similar to your infarction squares. And again, it demonstrates the same, pretty much the same thing. You have your different areas, your four walls, and then it shows you which leads to look in. It's color-coded, and it shows you which artery is supplying that area of the heart. And there's an illustration of the infarction squares in your text on page 320. Okay, so here we're looking at someone who has an acute inferior wall MI, and here's showing you lead 2. You see that ST elevation, as well as lead 3 and AVF. So right ventricular infarction. Right ventricular infarctions occur when the right coronary artery system is blocked, with damage extending into the right ventricle. Right ventricular infarcts are not detectable by your routine 12-lead EKG, okay, because remember, you're putting on your routine EKG, you're putting those leads on the left side, so it's looking at the left ventricle. There must be two conditions present in order to diagnose right ventricular infarction. Number one, you must have EKG evidence of an inferior wall MI on your standard 12-lead EKG. And number two, right-sided EKG must reveal ST elevation in V3R and or V4R. The right-sided EKG is only done if the doctor suspects a right ventricular infarction. So you're not going to just put the leads on the right side if you feel like it, you know, when you do the EKG. Your normal routine EKG, the leads go on the left side. A right-sided EKG is done when the precordial leads are placed on the right side instead of the left. However, your limb leads remain in the same place. And here's an illustration of that. Here we see your routine 12-lead EKG. You have your leads V1 through V6. And of course, on the right side, it's called, you have the R with the leads indicating it's the right side. Your landmarks will be the same, just on the opposite side. Here's another illustration of that, showing you your left side leads and your right side leads, okay? And then which intercostal spaces they're in. Now here's a neat little illustration of your different leads with your PQRST, showing your normal ischemia and your ST elevation. Okay, now who wants to act like a MI? Well, there are such things as infarct imposters, okay? And they are, number one, acute pericarditis. Now your pericardium is the double-walled sac that encloses your heart that serves to support and anchor it in place. When the pericardium becomes inflamed, it can cause ST elevation EKG changes that look similar to your MI. The ST segment with pericarditis produces a widespread concave ST segment, while the MI produces ST segments in the leads, which shows the blockage in the coronary artery. These different ST segments are referred to as your smiley face and your frowny face, okay? The smiley face is concave and your frowny face is convex. And you can see an illustration of that also on figure 14-15, page 330 in your text. And here's an illustration of what acute pericarditis looks like. And here where you see your ST segment elevation. Now here's an example of your ST segment elevation showing your frowny face and your smiley face. And you see here, and of course, if you're frowning, that's a clue. That's an actual MI, okay? Versus if it looks like it's smiling, it's an imposter. Here's your EKG strip illustration of your smiley face and your frowny face. And here's also another image illustrating your STEMI, with the your convex ST elevation. And here's what it looks like, your concave with early repolarization or acute pericarditis. So what is early repolarization? Early repolarization produces an ST segment elevation that can be either convex or concave, okay? This can be a normal variant seen in young people, especially young Black males. And the way the doctor differentiates the difference is he considers the age and the patient presentation to help identify whether those ST segment elevations that you see on the EKG are early repolarization. Early repolarization sometimes begin before the QRS complex has finished, and it produces what looks like a fish hook on your EKG at the end of some of the QRS complexes. And you can usually see that in leads V2 to V6, but you can see it in other leads as well. So here's an example of that. You see your ST elevation with early repolarization. And so it looks like ST elevation, however, it's not. And you'll see on, if you look at the ST elevation with your MI, you'll see where the different measurements, where that ST segment elevation actually starts to elevate with the MI versus where it starts with the early repolarization. Okay, so here's an example of the fish hook right here and right here with your early repolarization. So that gives you a more definitive clue that it's not actually an MI. And here we see another illustration of your ST elevation. And there it's concave, and then you have your ST depression. Electrocardiographic complications of the MI. So some degree of heart failure may occur as a result of damage to the myocardium. The heart tries to compensate by pumping more blood, pumping harder and trying to pump more blood out to get that cardiac output up, okay? But if your heart rate gets too high, there's not enough time between the beats for the heart to refill with blood, and this is known as decreased diastolic filling time. This causes the output to drop even more, and the patient can progress into cardiogenic shock caused from the catastrophic heart failure. Arrhythmias are common after an MI, such as that patient can progress into VFib, and if this happens, it's often fatal. Here are other EKG complications of an MI. You can see another illustration of some of these on page 340, table 14-3. They may have Mobitz 2 second-degree block, third-degree block with your wide QRS, sinus tachycardia, bundle branch block, ventricular arrhythmias, your VFib, hemiblocks, bradycardia, winky box, and junctional rhythms. Okay? So what are the warning signs of a heart attack? Well, again, they may present with uncomfortable pressure, describe it as squeezing, fullness, or pain in the center of their chest, lasting more than a few minutes. And remember, we talked about the 5 minutes. Shortness of breath with or without chest discomfort. Abdominal discomfort that may feel like heartburn. And discomfort or pain in one or both arms, the neck, the jaw, or back, or the stomach. Breaking out in a cold sweat, nausea, or lightheadedness. So what causes heart attacks? Well, that would be your clogged artery, okay? What can you do to help reduce your risk of heart disease? Well, you can maintain a healthy weight. I need a little help with that. Make healthy food choices. Stay active and stop smoking. And if you're going to exercise, you need to put your heart into it, okay? However, if your patient does have an MI, the treatment for an MI is they'll get to meet Miss Mona. And with Miss Mona, you're going to get morphine, oxygen, nitroglycerin, and an aspirin. So if your treatment for a STEMI versus a non-STEMI, the treatment is different. With your STEMI, you want to control that patient's pain because pain is dangerous for the MI patient because it causes your heart rate to increase and that causes more stress on the heart. They're going to get oxygen, the nitroglycerin, and aspirin, and within 90 minutes of getting to the hospital, they should have immediate PCI or percutaneous coronary intervention. And also, if possible, they need to get thrombolytics within 30 minutes of the onset. With your non-STEMI, they're going to get oxygen, beta blockers, antiplatelet or anticoagulant meds, and they're going to be scheduled for an angiogram for the doctor to determine the location of the blockage. So, okay, so here's an illustration of someone who starts to have the onset of MI symptoms. You're going to immediately call 911, and from the time the EMS gets on the scene and gets them hooked up to an EKG, they need to try to get those thrombolytics in the patient within the first 30 minutes and get them to the hospital immediately. And remember, we talked about our golden hour being the first 60 minutes, okay? Anytime after that first 60 minutes, you're going to start seeing more decreased chance of that patient surviving a heart attack. Here's an image of what your EKG strip may look like if that patient's having a heart attack. And then here we see if there's no symptoms, what your PQRST segment looks like. Here's if when they start with the acute onset of chest pain, you see the ST segment elevation. And then when they get to the hospital and the doctor gets them in for the angioplasty, gets the balloon in, okay, and then inflated, and they get the stent placed in to hold it open. Okay, so why should the EKGers win this contest? Well, let's talk about that. So if we let the coders win, then they just might call a code blue, and we don't want that, right? If they call a code blue, then you're going to have to get this thing put in your mouth and down your throat. And well, if somebody makes a mistake doing that, you just might get a tooth knocked out. So we don't want to have to see the dental people either. Okay? And now massage therapy is good. Unless you're this guy and your therapist's toes look like these. And then, well, if you have to go to the pharmacy, if you let them win, well, then you might just end up on the floor when you find out how much your medicine is going to cost. And then, of course, we need our medical assistants, but we don't want them to assist us looking like this. And, well, we just want to be able to keep an eye on everybody so that we can show them a little of our Southern heart hospitality. All right, so again, why choose us, the EKG team? Just listen to your heart because we care about your heart, okay? Now you can breathe. And if we don't win, well, we'll just see you later. And that's all I have for you guys. Vote EKG.